Hey everyone, welcome to today's webinar, Diagnosis of Discharge-Causing Infections via Optimal Sample Collection. I'm Melissa Davis and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by BD. To learn more, visit bd.com. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type into the Ask a Question box and submit. You may also use the Ask a Question box to let us know if you are having any trouble seeing or hearing the presentation. I'd like to now introduce our speaker for today's event, Dr. Barbara Vanderpool, Endowed Professor in Sexual Health Research, University of Alabama at Birmingham Heersink School of Medicine. Dr. Vanderpool, I will now pass it over to you for your presentation.
Great, thanks, Alyssa, and thanks to BD for organizing this talk. You are going to tell very quickly that this is something that I get passionate about. So you're going to learn more about collecting specimens than you ever wanted to know. But I'm just going to start this with showing you my disclosures. I have a lot. And the reason I have a lot is because I will work with just about anybody who is helping to get more tools out there for providers and clients to use to help improve their sexual health. So I think that, when everybody goes to market, we all win. So that's why I work with so many companies. You'll see on the left those companies that pay my institution via research grants to evaluate products. And you'll see on the far right those companies for whom I consult. And I also get salary support from UAB. No longer CDC in the current environment. I haven't scratched that off my list yet. I'm hoping it'll come back, and from the FDA as well. So why do I want to talk about optimizing quality of sample collection? I want to start by saying something I think you probably all really know, and that is that if we have a good quality sample, we can get a good quality test result. The reverse is, of course, true. If we have a poor sample, we may get a poor test result. So if you think, for example, about a pregnant woman coming in for a fasting glucose tolerance test, you're not going to order a plasma at 5 o'clock in the afternoon. Instead, you're going to prepare that patient to come in at a certain time of day to have not eaten, and then they're going to draw serum separator tubes. So we do this in the lab. The providers don't always see that back end of it, so you're maybe not quite as aware, but you do know it in the background, in the back of your minds. And I want to bring it to the forefront of your minds so that really you have a good reason to say, oh, this matters. And if I want the best possible test result for my client, it's probably worth doing this. So we're going to start with endocervical sampling for STIs. And I've got and vaginitis on here because the title of this talk said discharge-causing infections. And so that's why I'm going to put these together. And we'll come back to talk more about both of them. But for endocervical sampling, we've known for a long time, more than a decade, that this is less than ideal. Why is it still something that's out there? And why is it still something that manufacturers bother to take the time to get claims for? This is a holdover. When I started working in the 1980s and we started offering chlamydia culture as a routine diagnostic, we had to use culture. We needed live organisms, so we had to get them from the tissue where they were growing. That meant the endocervix. We did a lot of training with providers to say, don't collect an ectocervical specimen. Don't, no matter what you do, collect a vaginal specimen. We must have an endocervical specimen. So we spent a lot of time training people to do what we wanted. And that's what we needed for culture. But we're not in the culture era anymore. We're now in the era of molecular diagnostics that detect DNA or RNA. And from this large study in 2012, Showman and colleagues had almost 4,000 women enrolled. And if you look at the sensitivity for the endocervical specimens, it was under 90%, whereas self-obtained vaginal swabs, the sensitivity was almost 100%. So which one should you use? Well, I think it's pretty clear. And of course, self-obtained vaginal swabs are less invasive and therefore much more acceptable, both to some providers and to the patients themselves. But these data still are in most of the USA FDA submissions. So I took data that my lab had worked on because you saw that long laundry list of all the companies I work with. I have a lot of data in-house about how these things perform across a lot of different platforms. And so what I'm showing you here in the figure on the lower right is that vaginal swabs are always the most sensitive sample type. followed by endocervical specimens. So if you have an endocervical specimen and you want to test it, that's fine. And then followed by urine. What I don't show on here is actually that if you do an endocervical sample in a liquid cytology media, that's actually less sensitive than urine. So the reason for that is because of the dilution factor. You're taking a very small amount of tissue and you're putting it into 20 mLs of liquid. And so that's problematic. But people do it, and it's better than not testing at all. But endocervical specimens are obviously not ideal for identifying causes of vaginitis. And when I'm talking about vaginitis, those causes I'm going to include are BV, bacterial vaginosis, and they're also Candida species. I don't put Trichomonas vaginalis in the vaginitis category because it's clearly an STI, it's sexually transmitted. I think actually BV is sexually transmitted as well. And so I think that distinction between STIs and vaginitis is less clear than it used to be because our diagnostic tools have taught us about those infections. But so I've just said I didn't think urine was the best sample type, but it's still super common to have urine specimens come to the lab from people who have a vagina. So I want to just remind you, we have tons of data. This is a meta-analysis that we did a couple of years ago in my group, and we did a search for all of the studies that had both urine and vaginal sampling. And you will see there was only one study at the very top of this forest plot that found that vaginal swabs were worse than urine. Everything else shows that vaginal swabs are much more sensitive than urine specimens. So are we moving quickly toward vaginal swabs? No, we're really not. Now, this is a survey that was before COVID, so I know the data look a little old, but we haven't had the resources since COVID to do such a survey. But at that time, public health laboratories, over 50% of the samples that they got from people who had a vagina were still urine samples. So even in public health labs where they're very well attuned to what the data look like, the providers were still sending urine samples. Now, why is that? Well, I was doing a search on the internet the other day, which is always a bad idea because I think misinformation abounds, and that's exactly what I found. Now, this blurb that I'm showing you here is actually from an insurance company that's trying to tell its practice providers how to maximize their HEDIS score. HEDIS is a measure of how well we're providing quality services based on different metrics. And one of the metrics is, are you testing 16 to 25-year-old women at least once a year? And according to this, the best way to increase your screening activities is to inform patients that chlamydia screening can be performed through a urine test. So this is a shame, right? Because we should be saying inform patients that we can do a vaginal swab and they can get quick screening answers. So this encouraging providers to still use urine is unfortunate. And I actually had an experience not long ago where I did a webinar, not on this topic, on a different topic. And at the end, one of the questions was from a person who said they were very excited to learn that we can now get a chlamydia result from routine urinalysis. And I said, well, no, unfortunately, we're not there yet. We can't do that. And she said, oh, yes, we can, because I went to my provider and I looked in the portal for my test results from my routine labs, and there was a result in there for chlamydia. And I called my provider and I said, why did you test me for chlamydia? And the provider said, oh, we didn't. It was just an incidental result from your urinalysis. So this patient was lied to by omission when they didn't tell her what they were doing while she was at her visit. And then she was actively lied to when she called and asked about it. So this is part of the problem that we have, is that people are so stigmatized about offering STI services that they often try to tuck it in and hide it from the patients. And that is something that you can do with urine and you can't do with vaginal swabs. So unfortunately, many people, especially if they come in with symptoms that might be a UTI, are asked for clean catch urine. But all of the assays that we have for chlamydia gonorrhea were approved for first void urine because we want the really concentrated first little bits that come out and might contain all of the bugs. Remember, these bugs are not growing in the urethra usually. All you're getting in a urine specimen is drip down from the vagina. And so that gets diluted as the volume of urine increases. And if you do a sterilizing wipe first, and then do clean catch, your sensitivity for urine goes down to about 80%. So if you're using residual urine that was collected for a different purpose, you may be missing up to 20% of infections, and that's a disservice to your clients. So urine is still common, and we need to really think about why we do that, because collecting vaginal swabs is super easy. The only thing that I think really stops us is that residual stigma that I mentioned a minute ago. But if you're going to collect vaginal samples, yeah, it's super easy, but again, I'm going to emphasize, quality in, quality out. So if you have a good quality sample, you're going to optimize your test accuracy. Good quality samples also reduce failed tests. This usually happens because the DNA or RNA amplification process cannot occur because there's something in that sample that inhibits that process. So if we can get rid of these failed tests that are reported out as invalids, and we in the lab know you hate them, we don't like them either, but it reduces retesting, it reduces extra visits, and it improves patient and provider experience. So there's a lot of reasons we really want to work to make these samples the best samples that they can be. So the most commonly seen two issues. The first is use of vaginal products. And I say here within a few hours of sample collection, but I'm going to be really honest and tell you we don't have good data. I can't tell you what the time limit is. I don't know if it's 2 hours, 4 hours, 12 hours, 24 hours. We just have no data. But we do know that certain products like Refresh and Replens, which are two of the most commonly used products for lubricants, contain known inhibitors. For some reason, KY doesn't seem to, but the Refresh line of products does. But then there are a whole bunch of products we know nothing about, and that includes things like Lume. And I assume you're all familiar with Lume, but if you're not, their sort of promotional scheme is to say this is something you can use in any crack, crevice, nook, or cranny to reduce unwanted odor. Well, unfortunately, I have learned from many of my clinical colleagues that their patients are actually using Lume internally to reduce unwanted vaginal odor. That's not what this product was designed for. I don't know that it was evaluated in any way, shape, or form, so I don't know any of the safety issues, but I certainly don't know what it could do to the amplification process. So there's all kinds of things out there that people do that we're not always aware of, and certainly the manufacturers can't know everything. They can't know it before it comes on the market, obviously. So we never really know, but that's why asking about products is really important. And the second largest cause for invalid specimens is the use of a speculum for sample collection. This is really not ideal. And if you look at the package insert for every product out there on the market that has claims for vaginal swabs, it instructs the provider to collect that sample prior to speculum insertion. But it's not common, it's not everyone's practice. So this is the ideal sample, comes from the lower vaginal walls. What happens here is that the vaginal fornix has too much stuff in it. And so it can actually inhibit that amplification process because there's so much exudate and there's just that pool collected of white blood cells and everything else that's going on. So if we do the lower vaginal walls, we have a better chance of collecting the right amount of sample and the sample that we need to give us a good result. Further, beyond it being collected from the wrong spot, when you put the speculum in, you've just covered up that lower vaginal wall, so you can't collect from that spot. And some people still use lubricants with the speculum, and again, that may interfere with amplification. So it's really critical to ask about products and to collect prior to speculum insertion. And you're going to get tired of hearing me say that, but it really is a big deal because even remember that when companies do their clinical studies, and you can look at their package insert and see, or you can look at the papers that have been written about the products, they often exclude women who have used any kind of vaginal product. So we just don't even know what effect it has on some of the tests that are out there. So just be aware. And when you're taking these samples, if you are using the clinician obtained process, because this is preferred in some samples, if you want to collect a cervical sample because you're doing it for something else, you can, of course. But for STIs, and now even for HPV, everybody has claims for vaginal swabs. And since they work better, restrict cervical sample collection to only those things that need to be collected from the cervix. Now, if there's a cultural reason that someone doesn't want to do self-sampling, that might be a reason that you would do clinician-obtained samples. But still, a vaginal sample is preferred to a cervical, and a vaginal sample is preferred to urine if it's acceptable to the patient. There are cultural reasons, and there are also trauma-informed reasons why sometimes a vaginal sample is just not appropriate, and that's fine. Do a urine specimen, and it's the best that you can offer for that patient, for all the reasons that you've taken into consideration. But when you think about the workflow, just make sure that you consider all the molecular sampling that you're going to do, whether it's STI, vaginitis, or HPV. That should all be done first. It can be done by the patient or the clinician, but it should certainly be done prior to speculum insertion, making sure that you sample the lower vaginal walls. And so there are other processes that require speculum assistance. Those should always be done at the end. But should the clinician even be spending their time doing this? Because clinicians' time is the most critical resource that we have, because clinicians always are busy and their time slots per patient are so small and not always under their control. So if we can take activities away from the clinician and move them to the patient prior to even going in the exam room, again, it's a more streamlined workflow, releases some time for the clinician to spend talking with the patient about whatever issues the patient wants to bring up. So whether or not you're doing molecular tests, or even if you do non-molecular tests, which would include microscopy, there are some enzymatic tests that you can do for BV or for Trichomonas vaginalis. Vaginal swabs have been shown to be effective for that purpose. And this is all data from a study that Camus and colleagues did and published in 2021. They also collected information about patient attitudes, and most patients did prefer self-sampling, but still around a third of people said they preferred a clinician. But most of them, when asked, preferred a clinician because they didn't have confidence that they could collect their own sample well. So this may be an educational point where, again, if someone says, I'd prefer that you take it, say, yeah, sure, fine, I'll take it. But can I help you understand how next time maybe you can sample yourself and make it easier on yourself? So ideally, the patient self-collects prior to an exam. They collect their vaginal swabs first, and then they collect any urine that you want for clinical use. Then when they engage with the provider, they ask about vaginal product use. And not only is this helpful for the provider to decide whether or not they should send that vaginal sample onto the lab, or whether or not they should come up with a different scheme, it's also a teaching moment, right? Because you can ask the person about what they're doing. If the person is using products like, for example, Lume, that you don't really know if it's good for them or not, you can just have a conversation about healthy vaginal microbiomes and how to avoid things that can hurt that microbiome, like douching or harsh cleansers. Just remembering that we should never discourage people from using vaginal lubricants, because I think that's important for many people's sexual health and enjoyment. But if they're using vaginal products, like, for example, somebody comes in and says, yeah, I just had sex this morning and I used a lubricant, consider urine, because it's still going to be better than nothing. And it's, again, for that patient at this moment, under these circumstances, the best test possible. Or you can consider remote testing options. And that just depends on your setting and whether or not you have access to the ability to do something like telemedicine, where you hand the person a kit and say, collect your specimen tomorrow. Don't use any products for the next 24 hours. Collect your specimen tomorrow, and then give them instructions on what to do with that specimen from there. All right, so I'm going to stop talking about how to collect vaginal swabs. I'm sure you're all doing your dance of joy now. But I'm going to wrap it up by telling you that vaginal swabs really are the best performing sample type, and it's important to ask about product use. Self-obtained samples work just as well, or often better, than clinician-obtained samples. They may have workflow advantages, but you do have to understand your patient's needs and concerns, because they're not going to be ideal for all patients. And if you do clinician collected, make sure you do it prior to speculum insertion. That's super critical. Okay, so I have been talking about STIs and vaginitis because, and I've said I think that the line is blurry now, because I think as we've started using molecular tools, we have so much more information, and we've been able to do really interesting studies, including partner studies. So I think we have pretty good evidence now that BV is actually sexually transmitted, because we can see reduction in BV recurrence when partners are treated. And we've known for a long time that Trichomonas vaginalis is sexually transmitted, but it gets put into vaginal panels because it's a vaginal infection. So that makes sense, but does it make sense to separate them? And I'm going to argue probably not. When I have my dream world, we'll have one test, not two tests, and we'll just call it a vaginal health panel, even though some of it's cervical health. We won't get into the nitty gritty of it. But right now we have all these options if you do get vaginal samples, and all of these options work with self-collected vaginal samples. So STI testing is recommended for women under 25 years of age, as I mentioned earlier, even if they don't have symptoms. But that's screening. But STI testing is obviously recommended for all women reporting vaginal or cervical complaints, which include discharge, pelvic pain, pain with sex, dysuria, and a whole slew of sort of overlapping vague but consistent symptomology. But those are exactly the symptoms of vaginitis, right? And in this post-COVID era where we find people are more reluctant to undress and have a full exam, even at our STD clinic here in Birmingham, we have patients tell us they're not taking their pants off. That's just the way it is. They'll go in the bathroom and they'll self-collect. But they don't, and they've come in with complaints and concerns. So you would think that it would make sense for them to say, oh yes, please give me a full exam. I want you to look and see what's going on. But a lot of patients don't. And so we have to find ways to provide services for those people. And that's going to be the vaginal self-sampling. So we can test for the causes of vaginitis, because you're no longer having the opportunity to actually look and go, okay, is this cervical discharge or is it vaginal discharge? All you know is that they have discharge. So it makes sense to test not only for the STIs that are recommended for testing with symptoms, but also for BV and Candida. But trichomonas should be tested with the STIs, but it's not always. And so one way or another, make sure trichomonas is in there, and I'll show you some data to show you why it really matters. And as I mentioned earlier, the good news is we now have claims for 2 different manufacturers to do vaginal self-sampling for HPV testing. But as a general rule, you're not doing that when people come in with discharge symptoms, and you're doing it in an older age population for screening. So there may or may not be a lot of crossover with those, but these are things that we can do all with vaginal swabs. I think it's exciting and a great opportunity. What are we doing right now for vaginitis? Well, it depends. And in some clinical settings, it's very biased and sort of judgmental. I went in many years ago with discharge, and my provider said, oh, you must have BV. Here's a prescription for metronidazole. So I said, because it's what I do for a living, well, how about an STI test? And they said, oh, no, you're married. You don't need it. Well, I don't go to that provider anymore, because that person was making assumptions and judgments about me, and that my marital status had some influence on my risk for STIs without asking about my risks for STIs. And even if I'm monogamous, I don't know that my partner is, and I can't guarantee it. So if I have discharge, shouldn't you be testing me for everything? So that often depends on where people go to seek help. The other thing is that a lot of people rely on clinical diagnosis for BV in particular, as this person did when I went in. And you'll get some people that do wet prep microscopy, or just evaluate the discharge, do pH, or do the whiff test to see for amines. But what you see from these data is the accuracy. This is not sensitivity, this is accuracy. Remember, accuracy is really often influenced by how many negatives you see. So if you have a lot of negatives that are negatives, it's going to make you look really accurate, and you can still miss a fair number of positives, which is not what you want. But if it's just BV, the accuracy is shown in blue. But when people have more than one thing going on, like if they have BV and Candida or BV and Trich, it goes down to the numbers in red. And so you can see evaluating the actual discharge goes down to 42% accuracy. So is there even any point? And so maybe people are right when they're telling us they don't want to take their clothes off and they don't want an exam, they just want a molecular test, because in fact, the exams weren't really fruitful anyway. We just didn't have the tools to understand how poorly they were performing. So just to share with you information about why I am so insistent about, I think we should offer comprehensive care to people who have symptoms. These are data from a study we did several years ago showing in non-STD clinics, women who came in with symptoms for vaginitis had a chlamydia rate of nearly 5%. And on the far right, I show you the national average as reported by CDC. So we expect 1.7%, but we were seeing 5% in people that had symptoms for vaginitis. Gonorrhea should be about 0.3% in the general population, but it was 1.3% in this study. And trichomonas, which I told you to keep your eye on, Trick, and don't ignore it just because there aren't a lot of good recommendations around it, was very, very common, almost 10%, and it was more than 4 times higher than what we'd expect in the general population. Do note that in the general population, trichomonas is still the most common STI in women with symptoms. So we really need to make sure we're evaluating all 3 of these all the time. In a different study where we looked at causes of vaginitis, when women had BV, you'd see that 17% of them also had an STI. When women had Candida, 10% of them had an STI. When they had BV and Candida combined, 20% had an STI. So just testing for causes of vaginitis is inappropriate care because it just is not covering all the things that might be going on in that person. And if they can get BV, which is sexually transmitted, they certainly have exposure risk to STIs. So it really is worth testing for everything. Just to flip it on its head and look in the other direction, if people came in and had an STI, almost 80% of the women who had symptoms and had an STI also had BV. So just doing an STI test is not really the answer either. So just doing a vaginitis test isn't the answer. Just doing an STI test isn't the answer. We really need both tests. And what you see here is that any vaginitis, almost all of them. So there's something going on. And it's probably just because the STIs change the microbiome and people react badly and they develop BV or something else that's a dysbiosis concern. But this is a newer study just reported this year. And in this study, if a woman had BV, 50% also had an STI. And if they had yeast, almost 50% had an STI. Now, I've had providers tell me, oh, if you have yeast, you can't have an STI because yeast is just caused because you were on antibiotics, so the STI would have to be gone. Not really quite right. If we flip that on its head, anybody that had an STI, nearly 60% had BV and 25% had, and 25% had a yeast infection. So you can see that there's just a lot of overlap. So if a woman has one thing going on, she may have multiple things going on, and you just can't tell that with just one test. The added advantage of doing molecular tests to determine vaginitis causes is people that do that this is from insurance data, and what you see here from ICD-9 codes is that if people tested with a molecular test for vaginal causes, they were also much more likely to also test for STIs, meaning that we're starting to make that normative and just say, hey, you've got something going on. There's probably 5 causes that can be responsible for the majority of it. Let's test for all 5 of them. So that's what's happening when people start using molecular tests. So just to wrap this up, I think that it's important that we offer comprehensive care when people with a vagina come in with symptoms. And those symptoms can be similar for STIs or vaginitis, and women often have both. And clinical diagnostics are really just poor and can be biased and applied in a biased fashion. So we need to really think about that. So molecular tools now offer us easy means for comprehensive assessment, and it's not a panel, but it's a targeted selection of the 5 most common causes of lower genital tract infection. And I think given the fact that all of them can be transmitted sexually with the exception of yeast, I think it's important to say, okay, let's understand everything that's going on. And using a single sample for multiple tests obviously improves your clinical workflow. It does increase testing normativity, as I mentioned, which helps decrease stigma. If everybody says, oh yeah, these are the 5 things I get when I have a discharge, they stop thinking in that, oh, somebody just accused me of behaving badly and that's why I have an STI. So we get rid of all of that. But also from the clinical perspective, it results in fewer return visits because instead of treating somebody for chlamydia and having them come back in a week because their BV symptoms are still there, or treating them for BV and come back in a week because they've got gonorrhea, we can actually treat them for everything they have all at once. This increases patient satisfaction because they don't have to pay extra bills, they don't have to take extra time off work, and it reduces the burden on crowded clinics. So all the way around, this is a positive strategy for managing people that have symptoms. Okay, one last topic before we go to questions, and that is let's not forget the men. So men matter too, of course they do. And first, they matter because they impact women's health, haha. But partner management is actually very key to women's health. And all the platforms that we have out there have claims for testing urine from a penis for STIs. And so when we've done concurrence studies within partnerships, we have found that people don't have exactly the same things. So a man may have a chlamydia gonorrhea infection both, and the woman may have only chlamydia, or the reverse. And so we don't know, just because we know what a woman has, we don't necessarily know what her partner has. So we need to do the testing so that we don't waste antibiotics and we do treat appropriately. And also, among gay and bisexual men, and especially those men on PrEP, there are recommendations for screening for STIs every 3 to 6 months. And those recommendations also include extragenital sites, anal rectal sites, and the throat, screening for chlamydia, gonorrhea. So we know that urine from a penis performs really well on these platforms. We've used that from the first generation, and every test generation, they come out a little bit more sensitive. So we're hitting in the 95 to 100% sensitivity range for chlamydia, maybe slightly lower for gonorrhea. If there's ever a situation in which you can't do a urine specimen for someone with a penis, you can do a meatal swab for some assays. You'll have to check with your local lab that supports your clinic and see if the test that you're using has claims for meatal swabs. And swabbing the meatus is just really wiping a swab through the opening of the urethra, not entering the urethra. It's not an invasive specimen collection. But it doesn't have, there aren't that many assays that have claims for it. So it is somewhat limited, and I would really check before you do that. And I have never personally found a man who said they preferred a meatal swab to providing a urine sample. So for the most part, stick with urine because we know it works well. But remember also, it depends on sexual behaviors, right? So this is from a study of over 1,800 men, and you'll see that our prevalence was pretty low. We only had 10 genital infections for chlamydia that we had. This is from 600 some odd men. But we only had 10 genital infections, but all of those genital infections for chlamydia were everything that those people had. No man had oral pharyngeal anorectal chlamydia if he reported having sex only with women. Now, for those people who reported having sex only with women, we had one person who had gonorrhea in the anus or the rectum, and one person who had it in the oral pharynx and the rectum. So whether their self-report was accurate or not is unclear. But so while you're using urine, and here I've put genital, but it is urine, while you're using urine for testing men who have sex with women, that's probably appropriate. But when you test men who have sex with men, so gay and bisexual men, what you see is that if you used a genital specimen in the yellow circle, you would have detected 9 samples in the urine sample only, and another 3 that were in the urine and in the anal compartment. And so you would have picked up a little bit under 30% of the infections and missed 70. So if you only have the money, if you're a public health service or some community-based organization that has very limited funds, and you only have the funds to collect one sample, if a person is engaging in receptive anal intercourse, you need to be doing an anal swab. Now, anal swabs are just that. They are not rectal samples, and they can be self-collected or clinician-collected. I'm going to put an asterisk on that for just a minute and come back to it. But then I want to talk about GC. And again, you see with GC, you really need to be doing a urine specimen and an anal swab. If you can only do 2, the throat, you can decide if you want to do the throat. The throat infections are usually found in the other compartments as well, although in this particular study, we had 21% that were only positive in the throat. Unfortunately, we don't really understand the importance of throat infections and whether they self-clear or they're transmitted and what harm they can possibly do. So we're not really sure about the added benefit of throat. But if you can only afford to do 1, in gay and bisexual men, it should be anal rectal sampling. If you can do 2, add urine. And if you can do all 3, then that's up to you to decide if it makes sense for your population. And I said I was going to come back to the self-collection. Men, and I will tell you, every clinician I've ever talked to, they all prefer patient collection for anal samples. There's just a dignity, respect, and privacy issue here that makes it such that people really would prefer just to collect their own. So that's the way that we'll go eventually, but we're not there yet. And so that leads me to gaps that remain for supporting men in their sexual health. we really need claims for self-collection of these extragenital samples. There's a lot of data, especially from the UK, where we show that there are clinics that have been offering services to men for over a decade now, where men come in, they don't all see a provider. They go through an electronic triage process. After the triage process, they're given a kit of all the sample collection that they need to do, and they're sent into a sample collection room, bathroom, and they provide their specimens. They leave their specimens there, they go away, and sometime later in the day, they get a text with their results. So depending on what's going on with these men, but they found that they have very good performance for the self-collected specimens, and it's very accepted by their patient population. But in the US, of course, every lab that does this has to do validations of the sampling method because nobody has a claim for the sample collection process. There's no reason to assume that a patient-collected anal swab is different from a clinician-collected, just like it wasn't for vaginal samples, but no products have claims for this. Now, it's a common practice in many clinics to do a don't ask, don't tell process where they let the patients collect however they want, and there's nothing on the form of what goes to the lab that informs the lab that the clinic allowed self-collection, so the lab is happy not to know, and the lab just runs the tests. But it's not quite kosher, and it would be nice to have a system where we didn't have to do these workarounds. Not every lab can afford to do validations or has the resources to do validations or has the positivity to do validations. So it's quite difficult. So it would be really nice if we had claims for that. We also need claims for any kind of anal and throat sampling for HPV because rectal and throat cancers are becoming more and more common, and they're often related to HPV, but we don't have a test for that yet. And I think that that would be something that would really help improve men's health and be a positive benefit. Okay, so let me wrap it all up and tell you what I just told you. So, quality results start with quality sampling. And when you see sensitivity estimates, just remember they're based on the ability to detect what is on or in the sample. If you have an air swab, I can't get anything off of it because there's nothing on it. But if I have a low organism load infection, and I'm showing you here, and I know it might be small, but if you put a swab into a buffer and then you use your pipette to pull some buffer out, you might get a part that has an organism in it, or you might get a part that doesn't have an organism in it. So the test is accurate if it comes back negative because there was no organism in there. However, it's inaccurate because the person is actually infected. So collecting a good quality sample is really important to maximizing our opportunity to have enough bugs in that solution that we can detect them. And I'll just remind you that samples can suffer from insufficient sample collection or too much sample collection. It's just a bell curve like everything else. We don't want to be at either extreme. We want to be right in that sweet spot in the middle. And remember to ask about recent product use because that's something that can be really key for influencing the number of invalid results that you get. And I think that if we go forward with a focus on patient-centered options, we can minimize patient time and discomfort, and we can be mindful of patient-specific information, including cultural constraints. But for each patient, we should offer the best test option available. And so unless there's a reason that they don't want vaginal swabs, that's what you should be offering first. You should minimize return visits by testing for all pathogens that might be expected to cause the symptoms that are being observed. So that just is common sense. And now we have that capacity. So we should really think about doing that. And if we can do that, I think we will normalize sexual health care activities and reduce that sort of judgmental perception about who has STIs versus who has vaginitis. And so with that, I'm going to stop, and I see that there's a fair number of questions in the list, and so we'll start taking those.
Thank you so much, Dr. Vanderpool. Very informative. We will start the Q&A portion. Like you said, there are a good amount of questions within that box, so we'll start working through those. But if anyone has interest in submitting a question that they haven't yet done so, please do so within that Ask a Question box, and we'll try to get through as many as we possibly can.
I'll try to do short answers.
Yes. Sometimes it's hard though.
It is.
So I do want to feed off of one of your more recent slides that you kind of wrapped up on regarding having an inaccurate sample and then getting inaccurate or maybe incorrect results. And I think in the clinical setting, I know we didn't talk about UTI, but patients who come in with concerns of having maybe urinary frequency or burning. There is a need to do an evaluation of that urine for UTI pathogen, but also potentially for something like urethritis STI related. So when we think about appropriate sample collection, clean catch versus dirty catch, if someone needs both of those, do they need to get 2 specimens then for that patient? And what's the best way to approach someone in that situation?
Are you talking men or women? So
Let's
I'll
go with
do,
with vaginal first,
I'll
and
do
then
women first, yeah, because women do come in with UTIs a little bit more frequently than men. But what then would be ideal is have the patient self-collect a vaginal swab, and then have them wipe and do a clean catch so you can do a urinalysis appropriately for UTI and or send it for culture, right? So that's why clean catch is really important if you're going to do cultures for UTI, and especially if a person has persistent problems and you're concerned about resistance, you're going to want culture. So I would do a vaginal swab first, because you can't, as a woman, I'm going to tell you, I cannot do a first void, stop, clean, and start again. It's just not happening. So, it's not reasonable to ask the patient to do that. But a vaginal swab gets rid of that problem, right?
yeah, you need excellent pelvic floor muscle control to be able to do the start and
Yeah.
start and stop. So, but yes, I think that is the benefit, specifically with female patients, right? We always have the vagina to kind of fall back to for an additional specimen source as needed. With male patients, as you mentioned, it would be a little bit different of a scenario, but
And that may be the point at which that meatal swab actually works for you, right? Because you could do, I would assume in men, we usually rule out STIs first as a cause of dysuria. But if you don't, or you've already ruled it out, then, just your clean catch urine. But if you really think you want to evaluate this person at this moment for both, you could do the meatal swab, depending on whether or not your lab supports that. And then you could have them do the clean catch urine. So there is a solution for men as well. It's just not quite as widely available.
yeah, and I think it's very specific, like you said, to what they have access to. And so I think allowing providers to kind of step back and think through these potential scenarios and what the best collection options would be for these patients. I think a lot of the times, especially in female facing settings, right, you go in and you're told to like leave a urine sample immediately, and that's for like usually like ruling out pregnancy. But then you're kind of like, oh no, I wanted STI testing, or I feel like I have a UTI. And so there's a lot going on when you come in for those visits. And I wanted to also touch on regarding, I know you had mentioned the traditional office-based diagnostic methods that providers will rely on for like BV or Candida, but there's a question regarding, again, the accuracy of those tests and the fact that not often do providers have access to all of those options for like Amsel's criteria, right? Maybe they don't have a microscope, or the light bulb is out for that day, right? So when we take something that is already not super accurate and then we remove all of the criteria, we're left with really like subpar evaluation. I'd love for you to comment on that and the lack of access to those methods.
Right. And so that's what I was talking about when I showed that slide that showed that microscopy. I'm going to put it back up here for you. So these are the AMSL criteria that Alyssa was just mentioning, but this is if you just use one. So if you only had microscopy, your accuracy would be about 86%, or if you only had discharge to look at. But this is what happens then when there's co-infections, and so this goes down to even worse. So yeah, when you get down to only having one option for trying to test and evaluate for BV, it's subpar to begin with, and much worse if they have a co-infection. And the co-infections are just so super common that it's really quite difficult.
And as you've mentioned, right, we can kind of use one specimen. Vaginal specimen is kind of like, I always say, like, most bang for your buck, right, with a specimen source for a patient who does have a vagina and is symptomatic. So you can rely on those quality molecular methods instead of even really like spending your time performing the in-office procedures. You just know you're going to get a solid answer with molecular. So
Right. And I mean, like evaluation of discharge, which I think is what people think they're best at. And I'm doing a training process next week, and I know that the person before me is a clinician who trains on how to evaluate the appearance of the cervix or the appearance of the discharge. And then I'm going to come after them and say, oh, ignore it, because it's just really wrong most of the time, but it is what we teach people. And so we send mixed messages, during the training process. And that's why these webinars are kind of helpful, because they can help you rethink things that you learned. And sometimes, like in my case, I learned stuff 40 years ago and the world has evolved since then. So it's super helpful to see. And that's why I'm so, I know I'm a little bit number heavy and I show tons and tons of numbers, but it's because I really want to see data to help me understand best practice.
Oh, and the other component too with that in-office kind of clinical exam is we had a few questions that came through about like interfering substances, regarding it sounds like menopause related medications, right? And so there's over the counter and there's prescription medications, and pregnant patients who have maybe a higher risk potentially of getting candidiasis. And so, all of those factors, right, of these potential for interfering topical medications or potentially microorganisms really points to the need for molecular over those traditional.
Yeah.
We do have a question about the younger patient population under the age of 18, so more pediatric population, and what the best practice for sample collection for point of care testing for those patients would be, if you're able to comment on that. And this sounds like it's specific to the emergency department setting.
So I'm going to say, first of all, that the point of care setting will depend on what test you're using. Most tests for chlamydia, gonorrhea that have claims for point of care only have vaginal swab claims for people with a vagina. They don't have urine claims because urine is so insensitive, and you lose a little bit of sensitivity when you move into a point of care, process, just some of the chemistry that goes with it. So you were already losing some sensitivity, and then because the urine was less sensitive, people just haven't even bothered to try to get claims for female urine, with one exception. But that's a test that's a 90-minute test, so it's not a great test for use in the ED anyway. But I think the real point of the question is, what do we do about pediatric cases? And first of all, we have to rethink how we define pediatric cases. If you have a person that comes in and they have vaginal discharge or some sort of discharge, dysuria, pelvic pain, I had somebody talk to me the other day about, well, there was a 15-year-old and it turned out she had PID, but I couldn't believe she was having sex. And it's like, well, your first clue should have been the reasons that they came in. And so if they're coming in and they already have complaints that lead you to suspect an STI, and you shouldn't be testing if you don't suspect one. But if they have complaints that lead you to suspect an STI, they are sexually active. And if they are sexually active, inserting a swab just into the lower vaginal walls is not going to be something that's going to be painful or traumatic for them. Much less traumatic than a speculum, if you want to get right down to the nitty gritty of it, right? And particularly if you let the person do it themselves. Not everybody, but so many women use tampons that we're used to inserting things. And that starts happening when menses starts, right? So that can be 12 or 13. So it's not as if women don't understand how to put things in their vagina and take them back out of their vagina. And it's not that women don't, fear having something touch them. And again, take into account that there are cultural differences and some people do have issues with this. So I'm making broad sweeping statements. Now, some companies have claims for lab-based tests starting at 16. Some have claims starting at 14. Because it depends on the state, but in some states, people are emancipated for sexual health care starting at those ages. And if they're emancipated for that, collecting the sample for that is not problematic in most cases. But again, I'm not talking about sexual abuse cases at all, because that's, got to be dealt with in a very different way. So people need to understand who they're working with. But if it's a person coming in to an urgent care, and they say, I've got symptoms and they're 14 years old, well, you know, talk to them about, okay, can you collect this? Do you want me to collect this? And if they're like, no, 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 I don't want that, then offer the urine, right? But if you're trying to use a point of care test, the urine's probably not going to be doable. But for the lab-based test, you can do just about anything. Some states are rolling back. Alabama's rolling back that emancipation, and so people under 18 aren't even going to be able to access health care for sexual reproductive needs. So it just depends on where you live and what the laws are there and what the common practices are in the population you serve. So that's a non-answer, and I'm sorry. But as a general statement, most of these people who are sexually active, you can speak to them like adults and ask them to help you make that decision about what's best for them.
Yeah, and you did mention this, making sure that you're just checking the manufacturer's package insert or IFU for whatever STI assay your lab uses. They'll have the kind of intended age range and what was included in their clinical trial. So that can really help guide what is approved for with that assay, whether, it's a covered assay based on the state or, whatever insurance plan the patient has is kind of different.
Right.
But I also do like to kind of comment, this was with along the lines of the same question, is really making sure that we as providers, I say that because I'm a physician assistant, and clarifying with patients what sex means too, right? Because someone will be like, I don't have sex, but like they are 14 and maybe they had oral intercourse before, performed it or received it. And we really have to make sure that we are comfortable having those conversations about, like, you say you're not having sex, but what does that mean to you? Because that helps guide, right, what areas we want to test these patients for STIs as well.
Right. And I mean, I think sometimes we could even just say, have you had anything inserted into your vagina? Have you had anything that a partner inserted into? Because, God's honest truth is, and we don't have a lot of data on this, but some incidental data when I was working more with adolescents and when I was at Indiana, and, we had people that their partners had GC. It was almost always GC because that seems to be the most robust, I guess. But anyway, they had GC, and the only thing that they were doing was, like physical manipulation and using their fingers, but the girls were still getting GC. So, you can get some of these bugs in a variety of ways. And so, I mean, I think it's just worth saying, have you had anything inserted in your vagina as, with a partner? And have you had anything inserted in your rectum? And if the answer is yes, then test it. So, but again, I think you're right. I think that we've come to a lovely place in healthcare where the patient is actually part of the conversation. And I think that that's super healthy.
Absolutely. We do have one question about, it sounds like insurance coverage of these different tests. And if you're comfortable commenting, I can kind of give some input on that as well. But it looks like it's regarding kind of the full spectrum of broad testing for vaginitis and STIs all at the same time. And I don't know if you're able to comment on that, what you've seen.
It depends on the company, but more and more are. I think, in fact, what I have heard, and I have somebody that's actually in the process of doing, another pull from insurance data sets. But what we've seen, it looks like, is that the molecular testing for the BV in Canada actually is covered more often if you're doing the chlamydia gonorrhea at the same time. And of course, these are not screening tests. These are for symptomatic people. So there's a difference in reimbursement for screening versus testing people with symptoms. But if you just test for BV and don't test for the STIs, there's more pushback and denial of payment, which I think is interesting.
Sounds like they're encouraging at least ruling out the co-infections, though, which is very nice to some degree.
Yeah, I think so. I mean, I'm not sure exactly what's going on, but I think that I think the thought process is, if you think this is just vaginitis, all women need is the clinical evaluation. Mm-hmm. Oh, but if you thought it was something more, and that's why you tested for the STIs as well, then they need the test. So, I mean, I kind of think that's, but who knows? Who knows what people are thinking?
Yeah, well, and you made a good point too. Making sure when you do like a broad evaluation, including vaginitis and STIs, right? We're doing that in a symptomatic patient, someone who has concern for all of
100%.
those potential things, right? And when you look at manufacturer IFUs, again, package inserts, they'll mention if they have claims for symptomatic or asymptomatic, or both. And STIs are approved for both for most manufacturers. And vaginitis, when we evaluate for BV and Candida, is for a symptomatic patient only. And so I think that's where folks can fall into reimbursement trouble, is if they are just kind of testing someone who is asymptomatic and screening them for BV and Candida, which is not advised to do.
Right. And I think it ends up going back to the ICD-9 codes that you use, right? And so coding actually matters there.
And then speaking of symptomatic and asymptomatic patients, we have a lovely MGen question. So when we talk about patients who are symptomatic and asymptomatic, is it, in your opinion, important that we consider including MGen in that initial evaluation in either situation or both situations?
Okay, so you will notice I never mentioned MGen 1. And that's my personal bias, is I actually approve. I did not for a long time, but the data continues to come in. And I actually agree with the CDC recommendation that MGen should be reserved only for people who have unresolved symptoms. So you've tested people with symptoms for this panel of whatever it may be, and then if they still have symptoms following treatment for whatever you found, at that point, test them for MGen. And there's a couple reasons. And the first is we don't have great evidence that MGen leads to downstream consequences. So it appears that it may be one of those things that just tags along for kicks and giggles. So we know, for example, during vaginitis, M. hominis organism load goes up astronomically. But then when you treat for BV with a compound that is not effective against M. hominis, right? It's only effective against Gardnerella, really. The M. hominis organism load drops off again immediately. And what we think is happening is that the M. hominis is happy in the Gardnerella biofilm. And it makes a permissive environment, and so the organism load goes way up. But it's not the causative agent. And when the causative agent is taken away, the M. hominis goes back to commensal levels. I think MGen could be something similar. We just don't have great data, but it may be that it's so frequently there with chlamydia and gonorrhea. That's why they say test for these first, treat, and then if the symptoms clear up, fine. And MGen might have been there. But treating MGen because of resistance has become so difficult that we have to use really expensive and actually not very nice antibiotics. And so if all the symptoms resolve after treatment for chlamydia or gonorrhea, then let the person be. And maybe they have MGen and maybe it's a commensal for them, right? So that's why I think it makes more sense. Like I said, it's taken me a long time to come around. I thought the CDC guidelines were way too convoluted and way too complex. And I was all for screening for MGen, but as we've done that in my lab and we get more and more data and we see so many co-infections and we just don't see outcomes that are negative for most people.
Yeah, and I know, in clinical practice, I know MGen is included in a lot of tests or kind of panels that are not necessarily FDA approved, and they're when folks will go on to do some of these online services and they'll get tested for quote unquote everything under the sun, and or maybe they saw a provider in person and they said, I want to be tested for everything, and they include that. But then what happens, like, for those patients, this is like a question I pose to my patients is like, you're not monogamous, right? So like you are very sexually active. And so if you're going to get treated for this, what's the risk that you're going to acquire it again if you're not someone who is monogamous too? So we're throwing again ineffective antimicrobials or ones that have resistance concerns. It's a messy situation.
Yeah, it really is. It really is. And that's true for all of them. I mean, and the monogamy doesn't even matter because I can be monogamous, but my partner might not be. And I might know, I might not know. And so asking people about the number of sex partners, I actually find to be irrelevant because it's not about my sex partners. It's about all the people I'm exposed to through my one sex partner, So it's it's a difficult situation. I think that's all I'll say about it. But I'm not a big Amgen screening fan.
Right. Well, that is all the time we have for questions. We had a lot. This was lovely conversation. I just want to kind of wrap up. Thank you so much again, Dr. Vanderpool, for your time today and your important research that you've contributed to this kind of realm of science. I would also like to thank LabRoots and our sponsor, BD, for this educational webcast. Before we go, I'd like to thank the audience for joining us today and again for the interesting questions that came through. Anything that was submitted and answered via the speaker will not be addressed any farther. If there were any remaining questions that need answers provided, we can go ahead and reach back out to you via your contact information that you provided. This webcast can be viewed on demand. LabRoots will alert you via email when it's available for replay, and we encourage you to share that email with your colleagues who maybe have prior commitments or missed today's live event. So until next time, thank you and goodbye.